Just a couple of other questions for you all to kind of dig a little deeper in sort of the nuts and bolts of how some of the changes might affect people who are suffering today and are probably listening to this show saying, you know, what's Congress going to do to actually get some relief for my loved ones and my household. One issue I wanted to ask you, Dr. Thompson, because you've been looking at these issues, a whole host of issues, and cost issues as well. Do you have an idea of how much the shortages are costing the federal government in the form of reimbursement for costlier drugs? In other words, the kind of example that comes to mind is a brand name, drug that Medicare was, say, paying for, went generic. It's now on shortage, so I assume in some instances that brand name drug is being prescribed. So if that's the case, how many brand name drugs are there like that? And if you could give us some sense of the cost, that would be very helpful, because I think one of the issues this committee will have to wrestle with is certainly we're going to look at ways to get more affordable generics, these injectables in particular, out to people who are suffering. But people are going to say, well, that's going to cost some money. And if Dr. Thompson can enlighten us on whether the government is now spending even more money on these costlier alternatives in terms of the shortage, that might be a way to, make the case that, look, we can hold the cost down, here by cutting the reimbursement for the costlier alternatives. So do you have any sense of what the government is paying as a result of these shortages for brands?
We're just now beginning to drill down into our data to try to find some correlation to help answer that question. I think others may have a better answer than I do to this, but clearly if there's a brand name product available, that product costs more. And just the cost of...
How many drugs, can you give us a sense of how many drugs there might be? Would it be 5? Would it be 10? Would it be 20? How many drugs, even if you don't have an exact number, might fit this category of, brand name being reimbursed, say, by Medicare when there is a shortage?
Sir, I'd probably have to get back to you.
A significant number?
I would say a significant number.
So there's a possibility that this inability to fix the incentives may result in significant additional costs to taxpayers, to Medicare, for not dealing with the shortage.
I think that's a plausible thing
to
ask. Yes.
Let me ask you all one other one. Maybe we just kind of go down the row. If you're listening, to this, you or a loved one is suffering, you're waiting and hoping for treatment, and I've sort of reached the point working in these healthcare issues. I was director of the Gray Panthers for a lot of years before I came to the Congress working with senior citizens. People listen to these debates, and they want to know when there's going to really be a solution available. And of course, just plucking a date out of the air is pretty hard to do. But let's take the kind of situation where if the reimbursement issue was addressed in this committee, some combination of the policies that we're talking about here today, and as you know, Dr. Conti, I have some real questions just about the relationship between the physician and the manufacturer, and you gave some thoughtful answers on that. But let's say that issue is resolved. How long would it take to get these drugs produced and out to patients? Senator Cardin was absolutely right. People consider this urgent, priority. They don't want to hear about how it's going to take eternity. So as we wrap this hearing up, if this committee gets it right in terms of these reimbursement changes, how long would it take to get the drugs produced and out to patients?
I think that is one of the key questions in this issue. Unfortunately, I think the time frame varies quite substantially by generic firm and also by drug in terms of responding to these type of incentives. And I have seen estimates of anywhere between getting production up and running from 4 months all the way to 7 years.
So would it be fair to say, again, I want to use the terminology that I used with Dr. Thompson, because my sense is that there are significant additional costs to the government for paying for costlier treatments because the shortage is not being dealt with. Would it be fair to say of you, Dr. Conti, that a significant number of the drugs that are in shortage could get out to people, say, within 6 months? You said 4. Would that be a fair characterization?
I don't know.
Okay. Any of you others want to comment on a timetable? Because this is what people who are suffering want to hear, and that's why Senator Cardin asked, the question. They want to follow these debates, but they want to see that sense of urgency. Any of the others want to give us a sense of the timetable?
Yeah, I think the economic incentives and changing the pricing environment that we talked about here today is important for getting new manufacturers into space and for expanding capacity to manufacture these drugs, but it's not a short-term solution, in my view, in terms of the next 6 months type of solution, because switching over an existing manufacturing line to make a new drug, you're probably looking at a year under optimistic situations. Standing up new manufacturing, you're looking at 2 to 7 years, and probably closer to 7 years to stand up a brand new facility de novo. So that's a long-term solution to make sure that these markets don't get into trouble again in the future. I think shorter term, we need to look at the existing capacity that's been taken offline. That's our best bet of trying to alleviate the shortage within the next 6 months. And I don't think there's any, I don't think it's a sure bet that that's going to be a very efficient process getting those facilities back online.
Well, they're not mutually exclusive. There can be efforts to
Absolutely.
deal with expanding capacity in the short term, but I continue to believe that people want to hear how long it's going to take to get at the root cause. I mean, we're wrapping this hearing up, and you all have been very, very helpful. And for me, what it comes down to, Dr. Cobb, is what you said several hours ago when we began. To have you and wonderful practitioners on the front lines in this fight against cancer, like Dr. Drucker, to have to say to patients every day in America, drugs that will relieve your suffering and relieve your pain, they aren't available. We're not completely sure why, and having all kinds of debates in Washington, D.C. That's just not acceptable. So we've got to find a way to speed this up. We've got to find a way to speed this up in terms of both the short term that you just touched on a moment ago in terms of capacity, and then we've got to shorten that kind of period for dealing with the root cause of the problem. This is not acceptable, in my view, to say to cancer patients, well, we'll see what we can do in 7 years. That's just not right. Would any of you like to have the last word? With the last word going to our witnesses? With that, you all have been very helpful, and I think you're going to see significant bipartisan interest in this, and obviously this committee has jurisdiction over a key part of it, and led by Senator Hatch, we're going to get at it. Thank you all.